Good morning, everyone. Thanks very much for joining us today. My name's David McNally and I work for the North West Ambulance Service and I look after community engagement resuscitation for the Trust. During today's session, we're going to look at how we can perform basic life support and increase the use of an automated external defibrillator in the context of dealing with a child or infant patient. Like I say, we're using a live Teams version to deliver this session, so if you've never used it before, thanks for joining us, but if you have, great. You may see on the top of your screen 3 small dots. If you click on there, it'll allow you to put live captions on, and hopefully that'll be a transcript across the bottom of your screen. Also, there is the function to allow questions and answers, so please feel free to ask any questions during the session. And after the demonstration that I've done, we'll be able to go through those questions and hopefully I'll be able to provide an answer to them. So thanks for joining us. Hope you sat comfortably and off we go. So what are we going to cover in this session? We're going to look at and understand the principles of what we call the chain of survival. We're going to be able to recognise the signs of a cardiac arrest, be able to apply what we call the doctor's ABCD principles, understand what a defibrillator is, and be able to safely use a defibrillator. And the reason we're doing this today is internationally on Sundays, what we call Restart a Heart Day. And that's where we aim in every ambulance service across the world and different organisations to increase the awareness of how important these basic life support skills are to making that difference to somebody in a cardiac arrest. It's not just a one-day wonder for us. This is a year-round approach. And together with people like yourself on this call, we can make a difference to those people. So how do we know and what is the chain of survival? The chain of survival is built up of 4 links in principle, and there's different connotations of these out there, but each link plays a vital part in helping us to hopefully save somebody's life. First and foremost, when we recognise and we see somebody who needs help or we ascertain that they're in cardiac arrest, it's ringing 999, asking for the ambulance service, and then we will be able to help and assist you as a caller how to perform these skills. We can offer what we call Telecommunicator Cpr. We can instruct people how to do these skills by placing your mobile phone next to the casualty, having it on speakerphone. The call taker, an emergency medical assessor, will be able to take you through that system to help you build the first chain of that chain of survival. So as that telecommunicator CPR is given, you'll be able to physically perform the CPR skills. And what CPR stands for is cardio, the heart, pulmonary, the lungs, resuscitation. So we're actively trying to resuscitate the body and perfuse the body with oxygenated blood. In principle, when somebody suffers a cardiac arrest, the heart stops and somebody will stop breathing. And time is of the essence. And when we say time, we're looking about a 4-minute window to start to perform these basic life support skills. Because once the heart stops beating, oxygenated blood stops perfusing the body. And the vital organs that are essential for life are the brain, heart, lungs, and your kidneys. So during this CPR, we're artificially perfusing those organs by compressing the patient's chest. We're squashing the heart to push the blood around the body. CPR is commonly referred to as BLS, which stands for Basic Life Support. And when we say the word basic, that doesn't mean it's not important, because these are the fundamental principles of helping to save somebody's life. Another link in the chain of survival is the early advanced care. That's us turning up in the ambulance. And as a paramedic, for the years that I've been there, it's really important that we get there as quickly as possible. And we will get there as quickly as possible, whether that be in a rapid response vehicle, whether that be emergency ambulance. There's the HEMS air ambulance as well, and even cycle responders in built-up city areas. They're the key to another essential link of the chain of survival, where we can do advanced procedures. We can put needles into arms to give drugs. We can put tubes into people's throats to help ventilate that patient adequately. But if the basics aren't done first, we're always going to struggle to have that successful outcome. Unfortunately, there is a missing link commonly there in what we term pre-hospital cardiac arrest, and that's early defibrillation. These are the machines that we can see out there in communities in locked yellow boxes that are available for anybody to use in an emergency. And if we can bring a defibrillator into the context of this cardiac arrest, we can have an 80% chance of survival for that individual. But more importantly, if we can make sure all those 4 links are in place, we can give that person the best chances of survival. But if we take one of those links away, or we have a missing link or a weak link, the chances of survival drop steeply. So defibrillators can be accessed in various things, and we'll talk about that as we go through. But let's look about how we perform basic life support. We're going to remember that for this session, we're looking at infants and children. So the purposes of this, and it's in a layperson context, an infant is classed from 0 to 1 year. A child is classed as 1 to 8 years, and an adult 8 years and above. And there is previous sessions on our website and our YouTube channel how we perform CPR in an adult context. But we did get asked last year when we did this, could we concentrate on infants and children? So that's what we're going to do. I'm going to ask you to remember 7 letters, and those 7 letters are broken down into doctors and the first 4 letters of our alphabet. And each one of those letters reminds us to do something. And as a paramedic, it's the same letters for me. And I apply these principles when I'm dealing with emergencies as well. And remember, if in doubt, dialing 999, asking for the ambulance service, because we're there to help and assist and give advice. So what do the letters remind us to do? So first and foremost, D is for dangers. Is it safe for us to help that casualty that we have found? Now, if it's in your own home environment, that's okay. You know, you may know what's present and what's there. But if you're out there in the streets and somebody's shouting for help, we want to make sure it's safe for us to approach that casualty and help them. We don't want to put ourselves in a dangerous situation and become another casualty. So looking around above, is anything going to fall and hit me? Is it on a road? Is a car going to come along? Is there any electrical wires around that casualty as I kneel down are going to hurt me? So we're going to try and remove the casualty from the dangers, or remove the danger from the casualty. R is for response. Now, obviously, infants and children may not be able to elicit a response as we would do as an adult, saying, yeah, I'm fine, get off me. So we need to be gaining an age-appropriate response. If it's a child, it's a gentle shake and shout, looking for that smile, that gurgle, that giggle. If it's a younger child, that, oh yeah, I'm fine. We're looking for a response, because that's telling us 2 things. If we gain a response from that person or that child or infant, it means that if they do respond to us, the heart is working and the breathing of some description, and that's really important. But it's when that child or infant doesn't respond to us that we have to do something. And first and foremost, it's shouting for help. It's staying with that person, that child or that infant, and getting help, alerting another adult, alerting another child or somebody in that house to get help, ringing 999. Then it's on to our alphabet. A stands for airway. It's really important that we have an open airway in the child or infant, because if that airway is blocked through any way, through a foreign object or a tongue, that airway is going to stop air going into the lungs and stop that person breathing. And this is where the differences come in for children and infants. So if we take an infant first, 0 to 1, infants predominantly have a larger head in proportion to the rest of their body. And it's normally the back of their head that it's called the occipital area. And if we were to lie a child flat on their back, that airway would be partially occluded because the head would be pushed forward. So what we need to do is place the child in a neutral position. And I'll demonstrate that on the mannequins we have later in this presentation. But when I say a neutral position, it's placing something under the shoulders just to bring the head back to create a patent airway and a straight airway down. And that will allow a free passage of air through the mouth, through the airways into the lungs. Now, when we look at children, we have to change that slightly. We use what's called a sniffing position. And that's where we tilt the head back to allow the airway to be patent. We don't want to overextend a child's neck because that kinks the airway and will cause a blockage. But to the same extent, we don't want a neutral position. So we do what's called a head tilt to allow a sniffing position and create a patent airway. And we do that on a flat, firm surface to make sure we've got that free passage of air. And once we've ascertained we've opened the airway, whether it be a neutral position for an infant or the sniffing position for a child, we go on to assessing breathing. And when we talk about breathing, we are looking for normal breathing. So children have a high affinity of oxygen. They breathe quicker than us as adults because of the way they mechanically are developing. The heart works faster, they have a faster heart rate, and they have a faster breathing rate. So what we've got to do is look for their chest movement. Now in infants, and especially young infants, they are abdominal breathers. So they breathe from their stomach more than the chest. So what we need to do is expose and see the chest, whether they've got baby grows on or jackets or swaddled up. We need to physically see that movement of their chest. And with a child, again, hand on the chest, looking for rise and fall. We're going to listen for noises. So normal breathing is quiet. Yeah, I've got 2 children. I remember listening to that baby monitor over the years and listening to that child snoring. When it was my son, my daughter used to keep us awake all night, so that was a different matter. But we're listening for those breathing sounds, and they tend to be quiet and regular. What is important, if it's a noisy or a gurgling or a stertorous type breath, that should start to ring alarm bells and kind of set alarm bells running to think that doesn't sound normal. And you may know your child or the infant more than you, whether it be your own grandchild, niece, nephew, etc. And we're going to feel for breathing. So we can do that by placing the back of the hand in front of the mouth to feel for expired cool air on the back of the hand. But what's important, if there's no breathing or no normal breathing present, it's making sure we've rung for help and we've got help or rang 999, placing the phone next to the casualty and listening to what the call takers are taking us through. Once we've ascertained that help's on its way and we know that breathing's in place, we're going to look at one element which is distinctly different from adults. So as a layperson in adults, we don't advocate rescue breathing anymore because we may not know that adult, there may be blood, vomit or things present. If it's safe to do so and you feel safe to do so, it's important that we look at what we call 5 rescue breaths first for infants and children. The reason being, as I've mentioned, is that children have a higher affinity to oxygen. So the reason that this cardiac arrest may have occurred is due to lack of oxygen. So it's important that we get some oxygen into their system. So if we take infants first, we form a seal, place them in the neutral position first with the shoulders slightly raised. We form a seal with our mouth over the mouth and nose of an infant, because obviously things are anatomically a lot smaller and closer together. We make a seal, we puff our cheeks and introduce a small breath into that child and looking for a simple rise and fall of the chest. And we do that 5 times. If it's a child, it's mouth to mouth, making a seal around the child's nose, pinching the nose, and again 5 small inflations to create a rise and fall of their chest. And as I've said, the reason to do this is try and ventilate the infant, as the primary cause of collapse may be due to a lack of oxygen. And medically, that's what we call hypoxia. And we do that if it's safe for us to do so. We look for initial response, and if there's not an initial response, this is where we move on to the C. And this is where we look at compressions. This is squashing the infant or child's chest to squash the rib cage, to squash the heart, to push the blood around the body. We kneel close to the patient. We place the infant on a flat, firm surface with the shoulders slightly raised. We open the clothing and we put 2 fingers in the center of the child's chest. And we compress directly down 1/3 of the child or the infant's depth of their chest. And when we compress, we release. And we do that at a rate of 100 to 120 a minute. And in essence, that's 2 per second. And we do that for 30 times and then perform 2 rescue breaths if it's safe to do so. If you don't feel competent or it's hard to do the rescue breaths, we concentrate on continuous chest compressions on that infant. So that means we do 100 to 120, 2 per second to keep on going. It's important that we release fully from the chest wall, but not bouncing on the chest wall, because when we release the chest, the heart fills up with blood again and allows us to compress that blood out again, and we keep on going. So I've just explained how we do that, and I'll demonstrate that shortly on infants. What we do with children is place the heel of one hand with the shoulder directly above the midline of the body, arm nice and straight, and compress directly down on the chest wall again, a third of the casualty's chest, that child's chest, releasing fully at the same rate of 100 to 120 per minute, so 2 a second at a rate of 30 to 2 if you're going to do the continuous ventilations and rescue breaths. If you don't feel safe or competent to do that, just continue with that chest wall compressions, third of the casualty's chest at 2 per second. And then we continue and carry on that cycle until we see signs of recovery. The ambulance service arrives and takes over. If you become physically too tired, there may be somebody else who can carry out this for you, or you can instruct somebody how to do this. But it's important that once we stop, we don't stop that cycle until help arrives or a defibrillator arrives. So these are the common signs in the UK which indicate that there is a defibrillator in the vicinity. And if you can look from the green background of these signs, it's very similar to the running man sign that we see out there. And these defibrillators are in many, many places. They're commonly referred to as an automated external defibrillator, or an AED. And what an AED does, it does all the thinking and all the analysis of that heart rhythm for us, and then allows us to deliver a controlled electrical shock to that patient, irrelevant of age, to hopefully restart that rhythm in a perfusing type way. And the sooner we can get that to the individual side can make a significant difference. And when the ambulance service is wrong, if we determine it is a cardiac arrest, we're able to instruct people where these defibrillators are in the community. So it may be in a locked yellow or green box on the high street, or in a community, or in a phone box. It may be in a leisure centre, it may be in a shopping centre, it may even be in a supermarket. But we're working more and more with organisations to register these devices centrally, and every ambulance service in the country is now signed up to this central depository of AED registrations. So when you do register it on the system, it allows it to come into the emergency system of the ambulance service, and we can direct somebody to it in an emergency. And we will do that if there's more than 2 people on scene with that patient. If there isn't, we'll concentrate on that basic life support to keep that heart perfusing the body and the vital 4 organs that are required. I'm just going to pause there and stop presenting. And what I'm going to do now, I'm going to move over to 2 mannequins that I brought. And I'm going to demonstrate how we perform the CPR, firstly on an infant. So we've got an infant here, an infant mannequin, of how we're going to demonstrate that CPR. So we've got the infant lying flat on the floor. What is really important is that we check for our danger around it. This is what a defibrillator looks like, and I'll come on to that in the context of this doctor's ABCD approach. So as we approach casualty, we're going to look for any dangers around the casualty. Is anything going to hurt me as I approach? No, there isn't. And then what I'm going to do, I'm going to place the child. I'm going to try and check for a response. Obviously, a young infant, I'll be looking for it. I'm like, oh, can you hear me? Trying to stimulate that response, that familiar gurgle, that giggle, that look. And there isn't any. This is a mannequin, so there's no response. So I'm going to place the child in the neutral position, hands slightly under the shoulders to allow the airway to open. As we can see, when the child's lying flat on the back, their airway tends to be brought forward. So lying something under the shoulder blades of that child, a muslin, a nappy, or a little blanket will allow us to do that. So that airway is now patent. I'm going to shout for help. Is there anyone in the house that can help me? If not, I'm going to get my mobile phone, ring 999, place it on a speakerphone next to myself so I can talk to the emergency services at the same time performing these skills. So my airway is now open and patent. I'm going to check for normal breathing. So I may need to take the baby grow, for instance, in this infant, off. I'm going to look at the chest wall. I'm going to place my hand on the chest looking for any rise and fall. As I mentioned, infants tend to be abdominal breathers, so they breathe from their abdominal area more so than the chest. So I'm going to look for a rise and fall. I'm going to listen for any abnormal sounds that may be coming out, any gurgling, any gasping type breaths. I might look at the complexion of the child, the infant, because when a cardiac arrest occurs, Around the peripheries, that means the external areas, especially around the face, become very blue and what we call cyanodes straight away, because blood pools to the core of the body, so it's taken away from the peripheries. If these are all absent, I'm going to think I need to do something. I'm going to confirm help's on its way. I'm going to think about my rescue breath, because this infant, I know the infant, I'm going to do something and I feel competent to do this. So I'm going to create a seal around the nose and mouth of this with my mouth. And doing so, I'm going to tilt the head back, make sure they're in that neutral. I'm going to look down the chest wall and perform very quick 5 breaths. See if there's any response. If there's not, I'm going to start with my compressions. So the landmarks on an infant, as we can see from the mannequin, is 2 fingers and an internipple line directly in the centre of the chest. And we squash that down 1/3 of the child's chest at a rate of 100 to 120 minutes and release them fully for each compression. So the child is there, so it's 1, 2, 3, 4. Okay, and then 2 breaths. Continue with the 30 compressions. Continue. And I will continue those skills now until help arrives or something like a defibrillator arrives. So an automated external defibrillator can be used on any age from 0 up. Predominantly if there's a higher makeup of children in that area, some nurseries, schools or clubs that have them, we advocate that they should have what we call a paediatric setting on them. But if they haven't, we just follow the instructions of the device. So to use the device, there's various different makes and models. This is a training device that I'm going to show you now. There's a big red arrow, and what I'm going to do is open the device.
Adult.
And it starts to talk to me. So
remove all clothing from patient's chest.
So I know this is a child. This device has a button that allows me.
Child mode.
Okay, so I've cleared the patient's chest and opened.
Pull red handle to reveal pads.
So when you do this,
look at pictures on pads.
As we can see, the pads are
apply pads to bare skin exactly as shown in the pictures.
But what these pads,
press pads firmly.
What these pads do, allow me to apply them to a child. So I'm going to take the first pad and place it in the
pads to bare skin exactly as shown in the pictures.
Chest, like so.
Press pads firmly.
Then I'm going to take the second pad and place it directly.
Apply pads to bare skin exactly as shown
on the back of the.
Do not touch patient.
And then apply the child flat. The machine has told me to not touch the patient. So everybody stand back.
Everyone clear. Press flashing button.
So we make sure everyone is away. A large orange button flashing, stand back.
Shock delivered. Provide chest compressions to the beat. The heel of one hand should be in centre of chest. The other hand should be on top of first hand.
So this is giving me adult advice, but I'm not going to place 2 hands on this child. And I'm pushing to the beat of the metronome now.
Remember to push deep.
And it's pushing me and it's telling me to do the compressions. Now this machine is set up for continuous chest compressions. So what I would be doing here is interspersing that with 2 breaths. And carrying on. And I would carry that on now until help arrives or I see signs of recovery from that infant. Okay, so I'm going to stop there. I'm just going to reset this machine and we're going to do the same principles on a child, which you remember what I said right at the beginning, a child is classed as a patient between 1 and 8. But we're still going to apply the same variations. So I'm just going to move that mannequin out and bring in another mannequin I brought along, which is a child. So it's the same principles, it's doctors A, B, C, D. So I'm going to look around the casualty to see if there's any dangers, which there's none present. I'm going to check for a response. Hello, can you hear me? Hi mate, can you hear me? There's no response from this casualty, this patient, this young child. Can I have some help? So I've done my doctors, I've shouted DRS. Then I'm going to look at airway. So with airway, I'm going to use what we call the sniffing position. Again, you'll see from the child's airway, lying flat on the back, it's slightly occluded. But what we don't do is what we do with adults and do head tilt chin lift. What we do is a head tilt to bring the head forward and allow that sniffing position to create a clear passage of air and the airway to be open. I'm going to expose the chest because I need to see if there's any rise and fall. And I can do that. So again, I'm going to hand on the chest, looking for rise and fall of the chest. I'm going to be listening for any abnormal sounds coming from the mouth, or place my hand over the mouth and feeling for any expired air. I'm going to do that for no longer than 10 seconds. If there's no signs of any normal breathing, I'm going to make sure help's on its way, phone on speakerphone again, ringing 999, and I'm going to look at our rescue breaths first because I know this child and I want to help him. So I'm going to pinch the nose. I'm going to make a seal around the mouth with my mouth and deliver 5 breaths to get a rise and fall of that chest wall. See if I get a response, which I haven't, and I'm going to start with my chest compressions. So chest compressions, the heel of one hand in the centre of the chest, keeping the arm nice and straight, and my shoulder is directly above the midline of the body. And I'm going to compress the chest 30 times. And I'm going to do 2 breaths. Straight back on. I'm allowing the chest to fully recoil each time. And I've minimised the interruptions from giving the breath to carrying out the chest compressions. And again, I carry on this cycle until help arrives, or the defibrillator arrives. Now, the important thing with the defibrillator is that you don't stop until the machine tells you to if there's somebody else to use it. But as I'm by myself, my priority now is to get the child onto the defibrillator. So again, same principles, red arrow, open the lid.
Adult mode.
We're dealing with a child here.
Clothing from patient's child
So I'm
mode.
going to press the button.
Remove all clothing from patient's chest.
So I've done that. I know my next step is to pull the handle.
Pull red handle to reveal pads.
Now, because we're dealing
Look at
with
pictures on pads.
a larger patient
Apply
here,
pads to bare skin exactly as shown in the pictures.
I'm going to apply the pads
Press pads firmly.
in the traditional, what we call apex sternum position that we would do for an adult.
Apply pads to bare skin
If the child was small and the pads were very close together, we would revert to what we did for the infant and place it anterior and posterior on the rear. But because of the purposes of this,
Apply pads to bare skin Do not touch
so
patient.
again, everybody stand back. You can see the positioning of the
Analysing
pads.
heart rhythm.
So everybody stand back.
Everyone clear. Press flashing button.
So again, a large flashing button on the device, stand back.
Shock
And
delivered.
what do I do?
Provide chest compressions to the beat.
So again, nice and
The
tall.
heel in one hand should be in centre of chest. The other hand should be on top of first hand. Push down deep.
I'm going to tilt the chest back, make sure I've got that knee.
Remember to push deep.
That's sniffing, seal. 2 quick breaths, straight back onto the chest. And we continue that until help arrives or we show signs of recovery. What the defibrillator does, it times for a 2-minute period, and if another shock is indicated, it will deliver that shock accordingly.
Push down deep.
What the machines will not allow you to do is inadvertently deliver a shock to somebody who doesn't use it. So they cannot be misused or used in a detrimental way to that patient. And that's how we will perform CPR in an infant and child. Okay, so that's the end of me talking and demonstrating. And what I'm going to do now is look at some questions that have been posed, and hopefully I'll be able to answer these for you. I really appreciate you joining us today. And I can see a few questions that have been published. Do all defibrillators talk you through the process? Yes, they do. Some of them also have pictorial images, how they go through the cycle of, in principle, the chain of survival. Some have an LCD screen that graphically show you, but they all have an audible voice prompt, and some have the visual voice prompt as well. So I hope that answers that one. If I'm the only person at home with a child, how can I perform CPR and speak with 999 at the same time? Which one should I prioritise? Hopefully I've explained about the use of mobile phones. Mobile phones all have a speaker function, so placing that next to the casualty, it's really important that you get help as soon as possible when you've found out that the child is unresponsive or the infant is unresponsive and not breathing normally. So what we should do, if you can, ring 999, place your phone on the speakerphone next to the child or infant, and then listen to what the instructions are, but applying those doctors A, B, C and D principles if there's a defibrillator available. Are all defibrillators very similar to this? Yeah, it's like Nike, Adidas, Puma trainers. They all do the same thing, but they look different. Some of them have a switch that turn on, some have a lid that opens, some have a tab that they pull that kicks it into action. They're all very easy to use. What is important is you don't need to be medically trained to use those devices. Anybody in the community can use them, and that's why we send people to them in an emergency. If you do work in a facility that has a defibrillator, familiarise yourself with that and find out the make and model, and there's many things on the internet that show you how to use them, but in principle they all fundamentally work the same. Can you explain in what scenario the lower pad will be placed on the lower abdomen? So the positioning that I've just shown you for the child is what we call an apex sternum positioning, and it's the traditional position of placing it on the upper right of the casualty and the lower left chest wall of the casualty. The reason that's done is because the biggest muscle mass of the heart lies in that direction, so we're passing the electricity through that. And it is all dependent on the size and the physical size of the person we're dealing with. Obviously, an infant, if we place the pads in that position, they would be touching, so it won't allow the electricity to conduct through both pads and through the muscle mass of the heart. So it's size dependent. If the pads are kind of touching on the chest wall on the front, that's when we revert to the anterior, posterior positioning for defibrillation. If the sorry, just scroll down. If the defibrillators are locked, how do you open? Really good question. Defibrillators in the community are placed in cabinets, and they do have a PIN code. That PIN code, if it has been if that defib in the cabinet has been registered with the ambulance service, that code is held with us, and we're able to instruct people the code to access it. The reason we have it in locked cabinets is, unfortunately, these machines are misused and mistreated by certain people or certain groups, and we have had many vandalised. So there's always that risk of, if we have it in an unlocked cabinet and we send somebody there in an emergency, we're never sure that it's even going to be in good working order. The beauty of these that are in communities, it tends to be central to the community, and people from within that community have placed it, and there will be a guardian of that device. So if we send somebody for it in an emergency, we will send a notification to the guardian that that device has been used. And the majority of cases, if there is an AED being used on scene, our ambulance crews are instructed to take that with them, back with them to station, so we can collect that, purpose it, resupply it, and get it back out there should it be needed again in another emergency. If clothing can't be unbuttoned, is it safe to pull over the head, or would you just lift as far as it is? So from a point of CPR perspective, if we've got lots of layers, it is important that we try and remove some layers. Yeah, try and get it over the head. If we're dealing with an unresponsive child or infant, the priority is to start that CPR. What does come with defibrillators tends to be a rescue kit, and within that rescue kit is a pair of scissors. So irrelevant of gender or of that child or infant, cut the clothing, expose the chest wall, or cut the sleeve so we can get to the back of an infant, so we can get to their bare chest. But yeah, we need to get them. Why is the yellow pad on the child placed further down the torso? So the defibrillator pads have a pictorial image showing you where they physically go. So we're just following the instruction of the sticker. And the reason we place one on the lower left of the casualty's chest, which I am shown in the demo, is because, as I said, the heart lies at an oblique angle 2/3 to the left of the body's midline. So the biggest muscle mass is actually in that diagonal place on the body. So we're passing the electricity through the biggest muscle mass, and that's why it is. If we put the pads the other way around, so the yellow one at the top, the red one at the bottom, it wouldn't make any difference at all to that actual defibrillator being delivering an electrical shock. You mentioned that, Captain Locktower, how are they unlocked in emergency? Hopefully I've answered that in the previous question. If it's been registered with the ambulance service, we will hold that in our system, and we'll be able to dictate that the code is ABCD 1234. That isn't the actual code, but for demonstration purposes, we'll be able to give that physical number out to it. What do I need to do if I see signs of life? Really good question. So if we see signs of life, it's important that we maintain that airway and we keep that airway patent. We reassure that child or infant. If they are unconscious, it's important we leave them in that neutral or sniffing position so that airway is clear. If they do vomit or anything, then we can roll the child onto the side, so then it allows that airway to be kept clear. Do defibrillators have an expiry date? So the actual defibrillator comes with a warranty, and that depends on what make and model it is. Most modern day automated external defibrillators have about an 8-year warranty. What does have an expiry date is the pads and battery life. So again, it depends on the make and model. Lots of mainstream defibrillators now come with a 4-year battery and a 4-year pad life. So when they're set up, the battery will last for a state of readiness for 4 years, and the defibrillator pads will last for 4 years. After that period, they need to be replaced. Some defibrillators have shorter pad and battery life. When the defibrillator is used, the pads are always replaced because they're single use. And again, depending on the state of the battery when the machine was deployed, the battery life will be looked at, and it'll dictate whether we replace the battery or not. The beauty of automated external defibrillators, they do self-checking of themselves. So they indicate if they are what we call rescue ready or ready to be used in a live situation. And they'll display either a pulsating green light, or they'll have an egg timer or a green ball present or a tick. And if for any reason there is a problem with the defibrillator, those rescue ready elements will change. So the green light may become a pulsating red light with an annoying beep, like your smoke alarm would do, or the green ball will flip to a red ball with a cross in it, or the egg timer will become crossed. So the machines self-test themselves. They don't need external power. They don't need pat testing. They don't need routine maintenance. They do all the maintenance themselves. We don't even have to turn them on to see if they're functioning correctly. They'll tell us if they're ready. What kind of thing would you place under the infant's shoulders? How big should this be? So again, an ideal thing is imagine two new nappies, that type of height, or a folded up muslin or a jacket or a blanket, just to create that neutral position. We don't want to push the shoulders too high that creates the head falling back too much. So an ideal thing is probably 2 nappies. You didn't put your second hand on top of the first hand for child CPR, although the defibrillator was encouraging you to use your second hand. Which is best? Yeah, like I say, the defibrillator was actually giving me the adult advice, and even though the child setting was selected, the reason I use one hand is because of the physical strength. And what we're only trying to do is squash the depth of the chest a third. So if you were struggling to do that with an older child, there is nothing wrong with using the two-handed technique. But what we don't want to do is over-compress the chest. It's always better to push a little harder than a little lighter, because if we don't push hard enough, we don't squash the chest. enough to create that perfusion around the body. I hope that. We have a defibrillator at our local theatre. Excellent. Hopefully it's registered. Would this automatically be registered for local use in the area? If not, how do we know? Really good question. So nationally, there is something called the circuit, and it's a simple thing to Google. And what that takes you to is the British Heart Foundation's Central National Defib Network. So I would ask somebody at the theatre, has this been registered nationally? If not, tell them to go to the circuit on the website, and if they Google that, I think it's the top hit. And we may be able to put something on our website to direct people to it where you found this link for. But when you go to there, that person will see how they can register the defibrillator, or that's how we can check it. If someone is in a situation such as being in a thorn bush and needs help, what should you do? Well, obviously safety is paramount. It's if we can get that person out of that bush without hurting ourselves the best we could. If somebody's in non-responsive in that area, we'd try and get that person out the best we could. But remember, it ain't safe for you to be in that position. Don't put yourself in it. Could the defibrillator endanger the patient if the pads aren't placed properly? What the defibrillator will do, if the pads aren't placed securely on the patient's chest, it will dictate and tell you to ensure pads are connected to the patient or attach pads to the patient's chest, and it will keep telling you that until the patient is correctly attached. How much gap should there be between the pads to use side by side? I'd say 2 to 3 inches, and there isn't any hard or fast rule to that, but I would say a clear gap between the pads is paramount. My daughter is 3 and has an MPA in her right nostril to keep her airway open. Due to this, I can't pinch her nose, so should I do over mouth to nose? Yeah, I hope you're never in that position, but really good point. If you're unable to pinch the nose, just revert to mouth, maybe blocking the other nostril, or do mouth to nose resuscitation. I've been told that sometimes ribs can break during chest compressions. If that would affect the way carried out, no. Ribs may get broken during CPR, but what we're trying to do here is squash the chest, squash the heart, to push blood around the body. It's really important that we put enough pressure on there. And broken bones can mend. Children's bones tend to have a lot more give in them. And if fractures do occur, it tends to be what we call a green stick fracture. But it's paramount importance that we push at least a third of the casualty's chest. It's only one shock given by the defibrillator. No multiple shocks can be given, and every 2 minutes the cycles are reassessed. And if another shock's indicated, it'll be delivered if appropriate. Can a defibrillator be used? Multiple people or do pads are changed after every use? They tend to be all pads are single use, so they're replenished. Can this session be watched back later? Yes, I'm sure this. Yes, we have recorded this session, so we've placed on our website, and along there we've got our adult session. So please feel free to share it with friends, family, and other parents if they haven't watched this. Why doesn't a defibrillator tell you when to perform breaths again? Will it just keep the machine is set up for hands-only adult CPR? During COVID, we reverted to no mouth-to-mouth resuscitation in adults. So that's why that defibrillator is set to that. What you need to remember is in a child, we do 30 to 2 if it's safe to do so, and just keep on going through that circle. I already know where our local defibrillators are located. Should we wait until the the 999 call has been answered, or immediately go to retrieve one? So first and foremost, it's knowing the code for that defibrillator. If it's a child, it's important that we start to do those CPR procedures quickly, and we'll send somebody if there's more than 2 people there at that cardiac arrest. How do I register a defib? Hopefully I've explained that, and we'll try and put some narrative on our website how you can do that through the British Heart Foundation and the circuit. Please can you confirm what side you put the pad at the top? Is it right to left? Yeah, so the first pad goes on the upper right of the casualty, on just underneath the collarbone, and the other pad goes on the lower left. Would it make a difference if you got the pads the wrong way around? No, it wouldn't, as long as there was good contact from the skin. Why does the defib tell you to use both hands, even if a child? What the defib does, it reduces the energy and the electrical activity current that's given to the child. It doesn't tell you to use one hand or two fingers. That's where this training's come in. Does the defib stop before shocking after breathing detected by itself? No, the defibrillator only picks up the electrical activity of the heart. So it doesn't tell you if a patient's alive, it will only dictate if a shock is needed. If you placed a defibrillator on somebody who didn't need it, how it was working, or myself, it would say no shock advised, start CPR. Hopefully you wouldn't, because that person is breathing normally. But if that person was not breathing normally, or you thought they weren't not breathing normally, still carry on that CPR, because some heart rhythms do not necessarily need an electrical shock. That's where the advanced care from paramedics come in. Do you offer training sessions for college that you're able to come into, allow students to practice this? We try to engage with groups. Unfortunately, because of the capacity and the needs, it is very hard to get everywhere. But please look and keep an eye out on the North West Ambulance Service website. And we have got a really good resource on there, which is our academy, North West Ambulance Service Academy, which has got loads of materials for youth groups, kids and ages, activities for young children to do. And it really is a new thing that we're bringing to the fore. And we have got these videos live, and we do other live sessions throughout the year. Can I just say thank you for joining us today as we bring this to a close? It's really important that we spread the word of this. I hope none of you ever have to perform these skills, because it is a very scary situation. But hopefully these simple skills that I've given you today will allow you to, if ever needed, to make that difference. Thanks again for joining us on behalf of the North West Ambulance Service. Please take care of yourself. Thank you very much for your time today. Bye-bye.